Hello, ladies and gentlemen. Welcome to attend our webinar today. Yes, this is Luke, and I am.
Luke, you are mute.
Now, can you hear me now? Okay.
Yeah.
Okay, so let me introduce myself again. This is Luke, and I am in charge of the everyday business in Saudi Arabia. And it is really my honor to have you here today. And Mindray, we are working here together with Ablafond to present our everyday solutions. And hematology is a significant product from Mindray, basing on the advanced technology. More and more customers now, including the central labs in the central hospital, choose Mindray to improve the efficiency of their lab. Currently, we are #2 brand in our Chinese market and #3 globally, and always wanting to provide excellent solutions to customers, not only the machines and the reagent, but also the academic platforms like today. So today we invite Dr. Anna from Spain and Mr. Mohammed, the application supervisor of the Abdullah Phones, to present a body fluid related topic. So the schedule here today, we can see, sorry. Okay, the schedule here today, we have Dr. Anna to present the contribution of the body fluids analysis to the diagnosis of malignant and non-malignant diseases. And then we will have Mr. Mohammed to present the Mindray high-end hematology solutions for body fluids. After 2 presentations, we will have our Q&A session. So welcome to if you have any questions, just send us by the chat box. We will collect the questions and then send it to our speaker. So yes, so first we will have Dr. Anna to present her presentation. Okay, she is the senior consultant in hematological laboratory CBD hospital clinic in Spain.
Edit ng video.
And also the vocal of the education committee of the International Society of the Laboratory of Hematology. So Dr. Anna, please share your screens and the presentation. Yes, thank you very much.
Thank you, Jean-Luc, for your kind presentation.
Yes.
Let me share my screen. Yeah, almost. Okay, so hello to everybody. Thank you to Mindray for inviting me to this webinar, and thank you to all of you to be here. I am going to talk about the contribution of the body fluid analysis to the diagnosis of malignant and non-malignant disease. This is my university, the Medicine University in Barcelona, and this is my lab, the core lab in the Hospital Clinic of Barcelona. So, cellular analysis of body fluids has clinical relevance, providing important information for the diagnosis of different pathological conditions, such as infections, bleeding, or neoplasia. The manual microscopic examination is still the gold standard method for cell analysis. Nevertheless, manual counts present inter-observer variability, being highly time-consuming and requiring well-trained professionals. So in the recent years, there has been a tendency to perform body fluid analysis on the automated cell analyzers. like Mindray 6800 plus, we are able to separate the different components, the different cellular components of the samples of body fluids. For instance, we can have the high fluorescent cells. In this region, we can separate the tumor cells or macrophage or mesothelial cells, other mononuclear cells such as monocytes and lymphocytes, also other blood cells like eosinophils, neutrophils, or immature granulocytes. So it's interesting that some analyses provide counts for high fluorescent cells, because in these clusters we have the neoplastic cells. As I told, in the high fluorescent cells, we have macrophages, mesothelial cells, and also neoplastic cells. The macrophages are cells with high median size, with a nucleus frequently in an eccentric position, with a spongy chromatin pattern, and with a pale and sparkling cytoplasm, with occasional small vacuoles. I will show some pictures from these cells. May present phagocytosis cells or particles, and isolated elements are usually seen. Cells used to be separated, not together. This is an image of a cytospin, and we can see on the top of the image a big cell with a lot of vacuoles and with a nucleus in an eccentric position. This is a macrophage, and the remaining cells are blood cells. This is a beautiful macrophage, also with a nucleus in an eccentric position and a lot of vacuoles inside the cytoplasms. What about the mesothelial cells? Mesothelial cells are also big cells with a rounded shape and variable size between 10 and 30 micrometers, moderate or low nuclear cytoplasm ratio, a nucleus round showing a spongy chromatin pattern and usually one nucleolus, basophilic blue cytoplasm, and these cells show clear lines between them. We call to these lines window frames. In this image, it's possible to see this linear frame among the cytoplasms of these two beautiful mesothelial cells. Look, this round nucleus in a central position, and also a blue basophilic cytoplasm. These cells are also mesothelial cells. Mesothelial cells used to show only one round nucleus in the middle of the cell. But some processes from different causes may trigger morphological reactive changes in mesothelial cells. In the same manner that we have reactive lymphocytes in peripheral blood, we can see reactive mesothelial cells. And some processes from different causes may trigger morphological reactive changes. Look the next pictures. Reactive mesothelial cells share morphological characteristics with neoplastic cells. The identification requires experience and skills. These reactive mesothelial cells are high size, frequently in groups. They show a round-shaped nucleus showing spongy chromatin pattern and one or more than one nucleoli. Some of these cells may show two nucleus or multinucleate. They may show small vacuoles in the cytoplasm and mitosis can be seen. Here we can see on the left a mesothelial cell with two nucleus and a very basophilic cytoplasm. Look the big size of these cells related with this lymphocyte next to this cell. And on the right part of the image, you can see a macrophage. The color of the cells is different, very blue, the mesothelial, a lot of vacuoles, the macrophage. The nucleus in the mesothelial cell is round and usually on the middle, and in the macrophage, the nucleus is usually eccentric. This is a very big mesothelial reactive cell. Look through the basophilic, the very basophilic cytoplasm. Also look to nucleus and also containing nucleoli. But if you look through the other cells in the image, you can see that other cells correspond to neutrophils. This is a beautiful mitosis. It's a mesothelial reactive cell in mitosis. And also next to this cell, we can see a lot of neutrophils. These images correspond to a pleural fluid in a patient, a young patient with a pneumonia. So in a pneumonia, the mesothelial cells, because of the infection, can modify his morphology, and they look as reactive, very big, very basophilic, with some nucleus, with nucleoli, and showing some of them mitosis. Now, neoplastic cells. These are the most important cells, and we should recognize the morphology of these cells when we examine body fluids. These neoplastic cells used to form cell clusters or cell nests. They like be together. Cytoplasms of the tumoral cells get together. They show different sizes, but bigger cells are the predominant. They show high nucleus cytoplasm ratio and more than one nucleus. Nucleus with immature chromatin may show large and prominent nucleoli, and also the cell show a deep basophilic cytoplasm. They may show polar location vacuoles in secretory neoplasm cases. Also, we can see abnormal mitosis. And a very important morphological aspect is the cannibalism. What does it mean, cannibalism? When we see a neoplastic cell that eats another cell, also neoplastic. And we can see signet ring cells. Neoplastic hematological cells used to be smaller in size, and they usually do not form clusters. In ascites, the most frequent neoplastic cells are from the gastrointestinal tract and ovarian carcinoma. In contrast, in pleural fluid, the most frequent neoplastic cells are from lung and breast cancer. This is a chamber of Neubauer showing very big cells that are together. They form like a cluster. So these are neoplastic cells in fresh. When we perform a migrumbal GEMSA staining, we can see these cells together and a very basophilic cytoplasms. Cells lose their individuality. And this is a cannibalism. It means that a very big neoplastic cells contain inside another neoplastic cells. This is a pathognomonic sign, a morphologic pathognomonic sign of neoplasia. When we correlate the counts between the BC 6800 plus and the manual method, we obtained a very high correlations coefficients, more than 0.21 for the total cells, 0.81 for the mononuclear, and 0.23 for the polymorphonuclear cells. If we separate cells, the different body fluids, the peritoneal, pleural, and cerebrospinal, we can see a very high coefficient correlation between the manual and the automatic cell counts. Also, the sensitivity and the specificity for pathological body fluids and normal body fluids is also, the values are very high, with showing p-values less than 0.0001. When we should to analyze body fluid morphology using a cytospin? When the cell count threshold is 250 by microliter for pleural and ascites, and the cell count threshold is 5 cells by microliter for cerebrospinal fluid. It means that if we have a pleural or ascitic body fluid and the cell count is more than 250, we should analyze the morphology to see which kind of cells are contained in this body fluid. We calculated a high fluorescence threshold. In our experience, this high fluorescence threshold is 9.5 cells by microliter. And when we do differential cell counts in body fluids, we need to consider all leukocyte types. It means that mesothelial, macrophages, and abnormal cells should be counted, in addition to the blood cells. And here we have an example of a non-neoplastic body fluid. The number of high fluorescent cells was 4. It corresponded to pleural body fluid, and we counted 72.3 mononuclear cells and 27.7 polymorphonuclear cells. The total cells in this case was 238 by microliter. And the cytospin showed blood cells with most of the blood cells correspond to lymphocytes. Another example, in this case, we have a lot of high fluorescent cells in a pleural body fluid, 671 by microliter. We have a lot here of high fluorescent cells and 79.5% of mononuclear cells and 20.5 polymorphonuclear cells. In this case, the total number of nuclear cells was 730 by microliter. This sample corresponded to a lung adenocarcinoma. And you can see here the cytospin of this sample with a lot of very basophilic cells showing vacuoles, and also you can see a big mitosis. It's a very abnormal mitosis. Another example of neoplastic. In this case, it corresponds to an acidic body fluid. The number of high fluorescent cells in this case was 14, with most of the cells were mononuclear, 94.4, and only 5.6 polymorphonuclear cells. In this case, the total number of nucleated cells was 1412. This case corresponded to a diffuse large B-cell lymphoma. So the cytospin, look, very big cells, very basophilic cells. In this case, we can see some separation among the cytoplasms because it's a hematological neoplasm. As I told before, the hematological neoplasm don't use to share the cytoplasm, but the organ neoplast they use to lose the individuality. Now let me show some clinical cases. These clinical cases were from our lab. The first one corresponds to a patient, a man, 56 years old, coming to the emergency department for asthenia, anorexia, and weight loss with 2 months evolution. Ascites is detected in the clinical exploration. The cell counts were 500 red blood cells by microliter and 410 nuclear cells. And if we look through the cytospin and we perform the morphological analysis, we can see some lymphocytes, but we discover big cells, very big cells, with several nucleus, with prominent nucleolus, with a lot of vacuoles, not only on the cytoplasm, but also on the nucleus. It means that this is an abnormal neoplastic secretor cell. Look, this very abnormal cell, also showing 2 nucleus, nucleolus, basophilic cytoplasm, vacuoles. Look, the size of these 2 lymphocytes related to the size of this very big neoplastic abnormal cell. In this case, the diagnosis was a gastric carcinoma. The next clinical case corresponds to a woman, 68 years old, coming to the emergency department for asthenia, anorexia, and weight loss of 5 months of evolution. But during the last week, she presented dyspnea. Pleural effusion is detected in the clinical exploration. The cell counts in this pleural fluid showed the 6190 RBC and 1850 nuclear cells by microliter. Again, a very big cell with a basophilic cytoplasm showing a small vacuoles just in one side of the cell. Look, the immature pattern of the chromatin and also look these several nucleolus. This is a lymphocyte, a small lymphocyte in relation with the very big neoplastic cell. What's that? If I ask you, what are you seeing in this slide? Which is the answer? The answer is that this is a cannibalism. It means that we have a very big neoplastic cell that is eating another neoplastic cells. Look through these vacuoles in one side of the external cell and also these vacuoles in the middle of the internal cell. Another cannibalism, two very big and very basophilic cells. This is pathognomonic of neoplasia. And the diagnosis in this case was a lung carcinoma. The third case is a patient, a woman, coming to the emergency department, in this case for bad general condition. Ascites is detected in the clinical exploration. 7,840 RBC and 350 nuclear cells were counted in this sample. Look through this very big cell showing a nucleus with an immature pattern of his chromatin and also two nice nucleoli inside. This is a secretor cell because this cell is showing a lot of vacuoles, especially in one side of the cytoplasm. In the same case, the morphology led us to discover this very big cell with two nucleus, immature chromatin, nucleolus, a basophilic cytoplasm with a lot of vacuoles, preferentially in one side of the cell. So look how important is the morphology, because in all these cases, we can do the orientation, the diagnosis orientation of the patient just in a few time, because the patient is arriving to the emergency room and we are going to inform this sample in a few, half an hour. Clinicians may have the diagnosis orientation. In this case, the final diagnosis was an ovarian carcinoma. The next case corresponds to a woman, 80 years old, coming to the emergency department for asthenia, anorexia, and weight loss, 6 kilograms in the last month, and ascites is detected in the clinical exploration. The cell blood counts show 5.6 leukocytes with normal differential counts, anemia with low hemoglobin values of 10.5, normal platelets count. The lactico deshydrogenase was high, 220 units per liter, and the beta dose microglobulin was also high, 8.5. And in the emergency department, in a chest X-ray, the clinicians detected a minimal pleural effusion. This minimal pleural effusion was enough to be able to do a diagnosis orientation of the patient. Look, the number of RBC was 300, and we counted a high number of nuclear cells, 6,400 by microliter. And look, with the low magnification, we can see very similar cells in all the preparation, and a lot of mitosis. It means that this tumor is proliferative. When we see a lot of mitosis figures, it means that we have a high proliferation in this tumor. The cells look like lymphocytes, but they are bigger with a very basophilic cytoplasm, and we can see also vacuoles on the cytoplasm and also on the top of the nucleus. You can see here mitosis, another mitosis. The cells are together, but the cells are separated. And in this case, the final diagnosis was a Burkitt lymphoma, but taking account that we made the orientation, the diagnosis orientation of this patient through a sample of pleural fluid. Next case is a woman coming to the emergency department for back pain, instability, dizziness, and loss of strength in legs. A cerebrospinal fluid sample was obtained with only 20 red blood cells by microliter and 180 cells, nuclear cells by microliter. Look through this beautiful cell. This is an example of cannibalism, but is an example of cannibalism in a cerebrospinal body fluid. Look and compare the size of this lymphocyte with this bigger cell that is eating to another malignant cell. This is another cell that we found in this cerebrospinal fluid, very big, immature chromatin, nucleoli, and basophilic cytoplasm. In this case, the diagnosis was a breast carcinoma metastasis. The next clinical case corresponds to a young man, 32 years old, coming to the emergency department for a confusional state. He was treated in the past for an acute promyelocytic leukemia. A cerebrospinal fluid sample was obtained and we counted 20 RBC and 120 nuclear cells. You can see these cells. These cells are cells with a very irregular nucleus, and the cytoplasms show a characteristic pink color because of the granulation, because of immature granulation. Also, you can see these cells. These are malignant cells. These are atypical promyelocytic cells, showing in some cases these splinters and showing this immature granulation characteristic of the atypical promyelocybes. So in this case, the diagnosis was cerebrospinal fluid infiltration by abnormal promyelocytes. It means that the young patient has an acute promyelocytic relapse, leukemia relapse in cerebrospinal fluid. The next case corresponds to a patient, a man, 46 years old, coming to the emergency department for an epileptic crisis. He was treated for urinary bladder carcinoma in the past. A cerebrospinal fluid sample was obtained with only 20 RBC and with only 120 nuclear cells. Look, the aspect of the body fluid sample when we look through the morphological analysis low magnification. We can see very similar cells, some of them with 2 nucleus and some of them containing a big vacuole inside. With a big magnification, we can see these abnormal cells with several nucleus, with nucleoli, and a very basophilic cytoplasm. These cells in cerebrospinal fluid means that the patient probably has a relapse of his neoplasm. Mitosis, it means that it's a proliferative tumor, very big binucleated cells, very abnormal cells. And at the end, the diagnosis was urinary bladder carcinoma metastasis. So let me conclude. Some conclusions of my talk is that we found an excellent correlation for nucleated cells in all body fluid samples between the results from the Mindray BC 6800 plus and the manual method. We found a cutoff value of high fluorescent cells provided by the automatic analyzer. We showed a great sensitivity and specificity to detect neoplastic cells. Morphology examination of body fluid cells is an essential aid in the diagnosis of solid tumors and malignant hematological disease. Thank you very much for your attention, and thank you again to Mindray to inviting me to this presentation. Thank you.
Thank you very much, Dr. Anna. I think it's very excellent presentations, and the cases you share, I think, will inspire us a lot in the daily work. Thank you.
Okay.
Okay. Thank you, Dr. Anna. Thanks again. So for the next report, we will have Mr. Mohammed from the application supervisor from Blaford to present us the Mindray high-end hematology solutions for the body fluid. Hello, Mr. Mohammed. Now you can share with us your screen now.
Okay.
Hello.
Yes, I'm with you. Thank you,
Okay.
Luke. Thank you, Dr. Anna. Assalamu alaikum. Assalamu alaikum. I would like to thank all of you for your time today to join us with our webinar, and we hope to get the maximum benefits from today. My agenda today will be for manual body fluid test and operation practices, and also automated body fluid test and case study, and also the performance of Mindray solution for hematology for BC 6000 series. Just to explain what's the body fluid, actually 60% of our body is water, and the water divided for extra and intracellular space. The extracellular contains almost 45% with, as a calculation, 15 liters. For type of body fluid which will be analyzed on Mindray solution is CSF pleural fluid and peritoneal fluid and also synovial fluid. Per the sample collection and handling, in case of in case of the protein and the glucose, the sample should be for CSF without anticoagulant, and the volume for the chemistry tube should be 3 to 5 ml, and this will be tube number 1. For gram stain and culture, it should be also for CSF all the sample without anticoagulant, and the volume of tube from 3 to 5 ml, and this will be tube number 2. For cell count and differential, it should be from tube 3 or 4, except in case of a traumatic tab is suspected, should be counted from first tube. And for other tests, tube number 4. For manual body fluid testing, and this is considered as example, we have, let us say, 180 microliter of CSF with 20 Samson. The Samson is a glacial acetic acid. Both of them should be for vortex and also stand for 5 minutes. And after that, we can count on the chamber under 200x microscopic count with to measure the 16 squares. And again, this is a sample, and that vary from lab to lab. About the color and the clearance of CSF, the clearance for CSF for normal sample always normal. So the clear that means normal. For turbid, the turbid for the clinical identification, the cell number increase sharply. So in case of turbid sample, as we see here, there is an increase of cell count. Cloudy turbid also cell number increase. For hemolyzed CSF, this is one of the options, should be from puncture or intracranial bleeding. And for xanthochromic, should be intracranial also hemorrhage. Other body fluid, for serous fluid, this is slightly different because there is some type of anticoagulant. So for RBCs, white BCs, and cell count differential should be with EDTA anticoagulant, and the volume from 5 to 8 ml. For chemistry, it should be with heparin or without anticoagulant, and the volume is more than the hematology. For gram stain and bacteria, should be without anticoagulant or SPS. The SPS, which is the sodium polyanethyl sulfate. For AFB, also almost without anticoagulant, or with any anticoagulant not contain a bactericidal or bacteriostat. Pap stain or cell block, also with none without anticoagulant or with heparin and EDTA anticoagulant. For synovial fluid also better to contain anticoagulant for cell count, heparin or EDTA from 3 to 5 ml. For chemistry tube, also fluoride is accepted or without anticoagulant. For complement, also without or with EDTA. Body fluid sample processing, there is a chance to make dilution for the sample and pre-treatment with hyaluronidase. For synovial fluid, always or most of the time will be sticky. So sticky, it should be pre-treated with saline or hyaluronidase. When we want to make a pre-treatment with hyaluronidase, should be add 14 units for each ml of fluid and keep the sample for 10 minutes on 37 degrees. This is just for transudate and exudate. The main difference between them by quantity of protein in transudate will be low, and exudate will be large quantity. And this is the difference between them. Mostly the exudate will be cloudy and specific gravity is higher than or more than 1.02. And the other specification. Now let me go for the Mindray solution as a principle and all the specification for tubes. About the principle of Mindray solution based on SF-cube technology. SF-cube means scatter and fluorescence. And as you see here, we have 3 detectors. The 3 detectors start from complexity by slide laser SS and cell size, which lead us for size by forward scatter. And also we have 3rd detector, which is fluorescence signal. This fluorescence signal dedicated for DNA and RNA of the cells. And also this is dedicated for those cells which have the DNA and RNA. Here for white BC differential, we are in Mindray using 3D differential. As you see here, for differential, this is the 3D differential. Here for lipid interference, as you see here, for this blue line, this is the lipid. So in our solution, there is no interference with lipid or any other type of interference due to white BC cells already dedicated. There is dedicated stain only for the white BCs. Another point in our Mindray solution, we have dedicated chamber for nucleated RBCs, white BCs, and basophil. So all this type of cells will be measured in one chamber without any extra solution or extra sample. And this is for automated correction for white BCs. So in case of presence of nucleated RBCs in the sample, the machine will give us corrected result of nucleated RBCs, number of nucleated RBCs per 100 white BCs, and also number of white BCs plus basophil. This is only in one chamber. And here for diagnosis, diagnosis for hemolytic anemia and monitoring for hemorrhage disease. The aim for all this actually for reduce the ratio of microscopic use. About platelets, as you know, in case of large platelets or fragmented RBCs, always there is interference between the platelets and RBCs. And the golden standard for reading RBCs and platelets by impedance in same chamber. But in our solution, in case of large platelets fragmented, our machine will move from impedance reading to reach for platelets optical reading. And this will give us accurate result of platelets. And also we can get the two results, impedance and optical. And also we have fragmented RBCs as or schistocyte. This is considered as also the same message from the machine. Again, we have immature platelets fraction. This is, we can get it from the histogram of the platelets optical. And the platelets optical, this is automatic rule built in the machine. Another patented technology in the machine, which is platelet deaggregation. In the lab, when we receive platelet sample with platelet aggregation, we have to ask for another anticoagulant and replace the EDTA by citrated sample, and run this sample for CBC machine to get only result of platelets. In our solution, as you see, what's the aggregation? The aggregation, the fibrinogen as a material will connect for the receptor on the surface of activated platelets. Actually, when I receive the sample in the tube, the platelets aggregation already done. So our reagent as a patented technology will remove by minimize the affinity between the receptors on the surface of activated platelets with fibrinogen and to be replaced by receptor block. So in this case, even this is activated platelets, but there is no action. That means the inactivated platelets around the area will not be activated. And after this reliable result for platelets, no need to send the sample for or ask for other anticoagulant. But if we want to make comparing between the platelets impedance by EDTA, this is the line, the blue line, as you see, all the result low, less than 100. And actually here we take the cutoff or the limit numbers to start from 100 as a number of platelets. For platelets optical, this is the line for platelets, and also the practical, we will ask for platelets straight. What the correlation between platelets optical from EDTA tube direct for the machine, or by change the anticoagulant. If you see here, the correlation almost same results. Another feature for the machine, which is a multi-fold counting in case of leukopenia and also in case of thrombocytopenia. Our machine will increase the number of counted cells in case of leukopenia to be 3-fold, and for the platelets to be 8-fold. Here, this is our sample. If our sample with white BC's number less than 2, this is 2 considered configurable, so we can change as on the user. But in our machine, we fix it as 2. If the result less than 2, the machine will increase count number to get accurate result. And same for platelets, this is number 50. If the result less than 50, the machine will increase the counted platelets to give us more accurate result. And here, this is some graph for comparison here. And our CV, as you see here, for platelets optical less than 10. Another feature, malaria screen. There is malaria screen. Our machine will label it as infected RBCs. And the infected RBCs, we will get absolute number and percent for plasmodium. And for the study, we use almost high number of sample reach for almost 900. We find the sensitivity 92.3 and the specificity 100%. About reporting result of body fluid, our machine can report 7 reportable parameters from body fluid sample and 11 research parameters. The parameter, the 6 parameter, white BC's body fluid as white BC's only. Number 2, total cells body fluid, total cell nucleated. This means this is RBCs and white BC's. And regarding differential, we have mononuclear in number as absolute number and mononuclear percent, and also polymorphonuclear in absolute number and polymorphonuclear percent. This is for the 7th parameter from body fluid is RBCs. We have another parameter, but this is with star. This is for research use only. High fluorescence cell. Just let me explain what's the high fluorescence cell. Our machine actually 6 differential. The 6 differential is the number 6 of the differential immature degranulocyte. But immature degranulocyte not start from blast, start from pro-myelo to myelo to met. What about blast? The machine can label the blast as fluorescent, high fluorescence cell. So this is the difference. This high fluorescence cell, mononuclear cells, as a total number here, we can white BCs, mono and polymorphonuclear, total cell white BCs and high fluorescence cells from body fluid. For high fluorescence cell may contain histocyte, epithelial cell and spleen cell. Body fluid for BC 6800 and 6000 can analyze peritoneal fluid, CSF, and all the type of what we mentioned. And also for reporting result with for RBCs and white BCs as a number, and also white BCs differential. Moreover, for research use only BC 6800 provide the differential result for eosinophil, neutrophil, as well high fluorescence cell. all this from the 3D scattergram. And this is the parameter, 6 parameter related for white BCs and 5 parameter for white BCs, 1 for total cells and 1 for RBCs. And this the 11 research for use only. The most important, high fluorescence cell. Result for background. When you want to run sample on the machine will move direct from blood mode to body fluid mode, and also the machine by itself will make a background to get the result 0. As you see here, the limit less than 0.003, but our machine almost insists to get 0 results. For the linearity also, our linearity starts from 0 for body fluid, so that our result is very reliable. Here, for linearity, should be start from 0.05, but our machine can get very low results with R square 0.99 and almost reach to 1. This for correlation with manual count. So this correlation with machine BC 6000 with manual, as you see here for white BCs as a total number, there's good correlation with R square 0.987. For total cell, including white BCs and RBCs, and also high fluorescence cell, R square 0.987. For for RBCs, also reach for 0.876, and for polymorpho shape, R square 0.916, and for mono also 0.916. As you see here, even in low number of differential, there is good correlation. Let us go now for some case studies. This is CSF sample. The result of BC 6800, RBC 0.13, this and white BC 0.08. For the result, for the instrument, result show significant increase in RBCs with relevant symptoms. Meanwhile, white BCs slightly increased. For the histogram, the RBCs show increase significantly and differential few spot, and high fluorescence cells show RBCs increase sharply. This is on our machine. If we want to compare with manual for the case, for the manual reading under microscope, the RBC is 0.135, and on the machine 0.134, and this is considered low number for white BCs. Another case, also CSF, we have positive result for white BCs with number 2.4. The instrument show white BCs increased significantly and no RBCs. For scattergram, polymorpho and mono and poly area, in confirm this significant increase white BCs. Now, under microscope, found almost polymononuclear. For the differential, this is the polymorphonuclear is almost 67%, as you see here. If we want to go for microscopic, this is the number, and this is the differential, 78, and this is the number 2.4 under microscope with machine 2.4, which is good relation, good correlation with numbers. Another case also for 100. The instrument show white BC is moderately elevated, mainly mononuclear. For scattergram, give us also mononuclear. For microscope, show few nucleated, almost mononuclear. Here, we get 9%, and under microscope, the result of differential 94.5. The total white BC is 0.35. To see here for the number 0.33, which is good correlation. For the last case related for the blast, this white number 1.4, and for the differential, the machine give us high fluorescence cell. So high fluorescence cell, this is related for blast. Let us see the analysis. Instrument result show white BCs increase mainly mononuclear, high fluorescence cell body fluid, significant increase, flagging white BC scattergram abnormal. When we see this message, white BC scattergram abnormal, that means we need to make investigation under microscope, because it's not easy, and also we cannot say this sample contains blast cell. We have to confirm. But for our machine, once it gets the result, again the machine will make another confirmation in iMessage to give me your sample contains high fluorescence cell. In microscope, it shows few nucleated cell and RBCs, some of them blast. If you see here high fluorescence body fluid as a percent is 12.6%. This is high fluorescence as a percent. For the blast, we have 17% of the total number of white BCs. And again, this is the total number, 1.6 under microscope. For the machine, the number was 1.4. For our Mindray solution, actually we have modular, which is called automation for CBC machine. This contains CBC machine, and we go for next slide. This contains CBC machine and the slide maker and stainer, and recently we add our own machine, which is digital morphology analyzer, which use the 3D. So this is all this full solution from Mindray. If we talk for Cal 8000, we can install up to 4 machines from BC 6800 plus, and the throughput for each single machine 200 tube per hour. That means if we connect 4 machines, we can get 800 sample CBC per hour, which is the fastest machine worldwide. Here we have some study from International Journal and Laboratory Hematology for Mindray BC 6000 body fluid mode performance of nucleated cells and differential count in ascitic and pleural fluid. If we go for conclusion, BC 6800 body fluid in ascitic and pleural fluid offer rapid and accurate cell in and differential count in clinically relevant concentration. As a number, linearity was excellent. As you see here, the R square 0.99, and that means there is no carryover. And also in ascitic fluid and the pleural fluid, rapid and accurate cell in differential count in clinical relevant concentration range. The next also there's evaluation for Mindray 6800 body fluid mode for automated CSF counting. If we go for conclusion, BC 6800 body fluid offer rapid and accurate count in clinically relevant concentration range, replacing LM for most sample. But as a number, for white BC's diagnosis agreement was 93%, with cutoff more than 5 cells per liter, and for polymorphonuclear and mononuclear cutoff, more than 50% was 91 and 92 respectively. 92 for mono and 91 for polymorphonuclear. Next case, continue. This for what? Yes, for BC 6000. Also, the same machine in the dialysis. For the conclusion, as a number, limit of detection and report 8 cells per microliter, which is very low number. That means the carryover almost will never exceed 0.05%. And also for synovial fluid counting, for reliability of automated synovial fluid cell count with Mindray, also BC 6800. The conclusion, the use of BC 6800 for body fluid for synovial fluid analysis. This is enabled rapid and accurate assessment. Also, as a number, BC 6000 light comparing with light microscopy was satisfactory for all the sample repeated with hyaluronidase display bias between 5.9 8.9 and 8.2. For body fluid review, for report result, and also this is considered as a sample. So this is vary from system to system and vary from hospital to hospital. The result, more than 10 cells per microliter, this is report directly, otherwise report less than 10 for the negative result. For flagging rule, actually for high fluorescence cell, no differential result, no need further review. So in case of high fluorescence cells with no white VCs, no need for any further review. This for shift in the day shift instrument and microscopic combined. For night shift, you have only the instrument and you can get the for body fluid, you can get reliable results from the machine direct. For department specific rule, setting low limit of cell count for review, setting rule for differential, and for automation and standardization of body fluid testing would be possible with automated hematology analyzer. Now, thoughts for automation body fluid, the dedicated instrument. Yes, in our machine, we can consider it as dedicated because there is separated mode only dedicated for body fluid. So it's the time for testing body fluid automation. Reference range determined for automated body fluid, no need to make that because there is good correlation between automated and manual reading. For interference analysis for body fluid with our technology as a fluorescence, no need for that, and also add high fluorescence cell. Review rule setting for body fluid, yes, for sure there's some rules. In case of high fluorescence cell, it's better to read under microscope. Turnaround time, yes, should be improved, and also for turnaround time, and sometimes we're talking about days, not only hours. Thank you. This is last slide.
Thank you very much for the presentation. I think it explains very well the Mindray machines, and also it's very clear that our advantage and performance on the body fluid test. So, ladies and gentlemen, after the presentation, we'll go to the Q&A. So if you have any question, please send it to me by the chat box. Here we have two questions for Dr. Anna now. Okay, so the first question is to Dr. Anna is, what is the significance of detecting crystal in synovial fluid, and is it necessary to include in the SF investigation? Hello, Dr. Anna, we cannot hear you now.
Sorry. Now
Oh,
it's okay?
Yes, okay.
In my opinion, it's important also to investigate the synovial fluid. This is the easier one. So I did not include the synovial fluid because for me, this is the more easy one. But we, in some occasions, we need to investigate the pathogeny of the arthritis. So in a synovial fluid, we need to do the leukocyte count, the differential count, the gram, some microbiological studies, and also crystals. We need to detect if this fluid contain crystals or not. With all of these studies, we can find out if it's a non-inflammatory problem or is an inflammatory problem. If it is inflammatory, maybe because immunologic origin or because crystals presence. The most frequent crystals in the synovial fluid are the calcium pyrophosphate. This is positive birefringent crystal. and also the monosodium urate. This is a negative birefringent crystal. If it is not inflammatory, maybe also septic, this fluid, and maybe also hemorrhagic. So we need to find out all these possible causes in the patients. So, of course, the synovial should be included in the study of all the body fluids. Okay? Another question that I saw is about the viscosity. The viscosity, in my opinion, is not important to look through because all the arthritis have, as a consequence, a viscosity diminution. So, in my opinion, viscosity offers low diagnostic information. And in my opinion, we don't measure viscosity in our lab.
Okay, thank you for Dr. Anna. I think you answered 2 questions, and I don't even have a chance to introduce the second question. Okay, so we have the third question. We have question for Mr. Mohammed. One audience want to know: do we need the pre-treatments on the body fluid samples, and if I want to use the hematology machine to do the analysis?
Actually, most of body fluid, no need for any pre-treatment or any preparation, except the ascitic fluid. Sometimes the ascitic fluid, synovial fluid, when you receive it as sticky, we can pre-treat with saline or hyaluronidase. In case of hyaluronidase, we have to increase 400 units for 1 ml of synovial fluid and keep it at 37 degrees for 10 minutes. After that, we can run on the machine. But most of the cases, no need. Also, we can check the sample by naked eye, if this is viscous or not.
Okay, thank you for your answer. So we also have another question for you. One audience want to know about the graph for the body fluid analysis. Is 2D or 3D?
For body fluid, no, it's a 3D, because body fluid, the machine consider the body fluid as blood cells, because we are in the machine looking for white VCs regardless the origin. So in our machine, it's a 3D. Based on that, we will have the high fluorescence cell as an extra differential in our machine.
Okay, thank you for your questions. And we have another question for you. For one audience want to know: do I need to buy a special reagent for the body fluid samples if I want to test?
No need. The machine will use same reagent what we are using for CBC sample, including the differential type.
Okay. Thank you for your answer. We have another question for Dr. Anna. The question is: what about documented reference range for the pleural and ascitic fluid?
There are several documents for pleural and ascitic fluid. I also wrote a book about body fluids, and in my book, all of these references are included. But sorry about that, but my book is in Spanish, so probably you prefer English reference. They are quite reference for not only for pleural but also for ascitic fluid.
Okay, so I think we will have the English version soon.
Pardon?
No, I mean I think we will have the English versions very soon.
Yeah, probably, yeah.
Okay, thank you. Ladies and gentlemen, do you have another questions you want to ask? Okay. Let's give the audience another 2 minutes for the questions. Oh, we have a question. What is the line register of the WBC count for the body fluids with the Mindray hematology analyzer?
For the linearity, it should be started from 0. Why? Because the low number is also considered significant in case of body fluid. So the number will start from 0 just to evaluate the sample. Is it the increased number of cells due to case of the patient, or this is due to puncture? So start from 0.
Okay, and also someone wants to know what is the time needed to get the result?
The result considered as CBC sample. With slightly more, because in case of high fluorescence cell, the machine need more time to make this evaluation, because this is considered more type of differential.
Okay. Thank you for your answer. Do you have any other questions? Oh, for Dr. Anna, well, we have one audience want to discuss about the co-reaction of the new latest RBCs that's counted as the lymphocytes in the hematology analyzer devices.
The correction of the that counted as a lymphocyte, and usually we do the correction manually. If we have a number of leukocytes and a number of nucleated RBC, we use like a formula with the leukocytes by 100 divided by the RBC plus 100. We use a formula to do the correction. I don't know if in the hematology analyzer device, probably the number of RBC are also counted. So if they are counted by the analyzer, I think we the correction, maybe the analyzer is correcting the number of leukocytes. But in my lab, we use Albia 2120, and using this analyzer, we have to do a manual correction like that. Leukocytes by 100 divided by RBC plus 100.
If I can add some point for this question, actually based on our principle, which is fluorescence, that means fluorescence, the dye dedicated for the nucleus or for the DNA and RNA. in our machine, the nucleated RBCs will be measured in the white BCs and basophil chamber, because there's another chamber separated for another differential rather than basophil. In this case, the result of nucleated RBCs will be really reliable. 100% is nucleated RBCs, not lymphocyte or other, because there is this is measured in dedicated chamber. There is another chamber for lymphocyte, and also in case of presence of nucleated RBCs, the result will be released number of nucleated RBCs per 100 microliter. This is to meet reading under microscope.
Okay, thank you for the answers from Dr. Anas and also Mr. Mohammed. So, ladies and gentlemen, thank you very much for attending the webinar here today. So we have a questionnaire here. Please feel free to scan the QR code and fill in the questionnaire, which could help us to improve for the next time. Okay. And also, if you need further information, about Mindray, about our academic activities, please feel free to scan the QR code here to join with us. We have the Mindray Middle East Facebook groups. We have the link in, and also we can scan the QR codes of our distributor to know more information about our products and our academic platforms. Thank you very much.
Thank you.
Thank you for all. Look, I see some people asking for the presentation. Actually, we will share the presentation with the same email what you register in the Zoom link.
Oh, okay. Yes.
Thank you
get
for
the. Thank you. Oh. Thank you. I will stay in this page in case there's someone want to scan the QR code for more information. And for everyone, good night.
Bye.
Thank you, Dr. Anna. Thank you very much.
Thank you.
What is the most important aspect in the relationship between patients and doctors, as well as being the vital link between laboratories and medical solution providers like Mindray? Like all European institutions, the Hospital Center of Libourne in France sets a high standard in accuracy and result standardization in their laboratory. The laboratory processes a large volume of samples every day. With Mindray's advanced cellular analysis technology, it is able to provide better patient care with faster delivery of reliable test results.
Nos métiers sont passionnants car malgré la standardisation et le grand nombre d'échantillons traités tous les jours par ce laboratoire, nous assurons des résultats uniques pour chaque patient.
Scientific Lab in Brazil has faced the same challenges as many high-volume laboratories. Its headquarters in Sao Paulo performs up to 9,000 hematology tests a day, putting great pressure on their laboratory to enhance productivity while maintaining high-quality service. Scientific Lab's partnership with Mindray has helped address this challenge.
Estamos instalando aqui, são 2 esteiras da Mindray, aumentando em torno de 50% a capacidade produtiva. Identificamos a necessidade de termos 2 esteiras semelhantes, porém uma diferente para a outra. Foi solicitado à Mindray uma esteira exclusiva que deixasse muito mais fácil, muito mais rápido, muito mais simples o nosso fluxo, né?
In Thailand, thalassemia is the most common genetic disorder and a disease burden for its population. The Institute of Molecular Biosciences of Mahidol University is dedicated to the advancement of technology in healthcare, with thalassemia research as one of its main focuses. Mindray, with its advanced diagnostics technology, has been supporting Mahidol University in improving their research capabilities to fight diseases like thalassemia.
After years of research, information and technology that we have been doing for years have been transferred to the existing healthcare system of the country, that is people in the Ministry of Health. And now Thailand is very active in the prevention and control of thalassemia.
Today we have information technology which is rapidly developing, is providing people in the medical areas with easy approach, easy access to knowledge. So it is very important that manufacturers of laboratory instruments and any industry working in the world of medicine be aware that they have a great responsibility of keeping people, up-to-date people, and permit the best use of their product.
Io penso che il laboratorio clinico e l'industria, pur avendo dei ruoli, delle finalità diverse, sicuramente rappresentano i 2 principali artefici della moderna medicina di laboratorio. Entrambe pongono al centro della propria attività l'innovazione, la qualità, ma soprattutto il bene per il paziente.
Mindray understands the unique challenges of laboratories worldwide and provides comprehensive, reliable diagnostic solutions to help address them. Mindray laboratory solutions are recognized by customers and partners around the world. Trust serves as the core foundation of every one of these relationships.